Hi friends, welcome to Charcos. I'm Dr. Seema Balian, the founder and director of Charcos. Charcos is a healthcare recruitment and training company with over 15 years of experience in providing turnkey solution for training and recruitment needs for the nurses, doctors, and AHPs such as radiographers, occupational therapists, ODPs, and many more. OSCE training for all fields of nursing such as adult nursing, mental health nursing, pediatric nurses, midwifery, and learning disabilities. OSCE training is available in India as well as in UK. Orientation for life in UK, OSCE exam bookings and the logistics bookings, excellent pastoral care. Our state-of-the-art learning platform includes reading materials, videos, quiz to enhance your learning and equip you for a positive and a better outcome. For more information, please visit our website www.charcosglobal.com. Our Facebook page, Instagram, and LinkedIn pages by the name of Charcos Global, and subscribe our YouTube channel. Press the bell icon for regular updates and all the information that you require. We are looking forward to seeing you on our site and being a partner in your enhanced journey. Thank you very much.
Okay, so as we discussed yesterday, so from today onwards, we are going to be starting the skills. Yeah, and but before we go on the skills, any questions on the APIE? No. Okay, that's fine. So then we can progress to the skills. Now, in the skills, in total, there are 10 skills which are there as part of the midwifery OSCE, out of which you are going to get in the exam any 4 of them. Okay, so if we look at that, okay, what are these skills which are there? So the birth itself, there are, I think there are 3 or 4 for the birth. Like there is a normal birth, there is the birth scenario 1, which is shoulder dystocia. Then there is birth scenario 2, which is the postpartum hemorrhage. And then there is complex birth, which is breech delivery. And then we also have the IV flush and VIP score, the urinary catheter removal and IM injection. And we then have postpartum care, postpartum check, and I think then this is one is where we are doing the examination of the newborn, systemic examination of the newborn. So these are the 10 sort of skills which are there. And out of this, any 4 you are going to be getting. So today we are going to be dealing with 2 of them. So the normal birth as well as the birth scenario 1, which is the shoulder dystocia. So I'm sure that both of you would have handled normal deliveries. Yeah,
Yes.
Mercy, Priscilla, both of you have handled normal deliveries? Okay, and
Yes,
are you otherwise fairly confident that, say, if today I put you and you need to do a normal delivery, so do you think that you are fairly confident in handling the normal delivery?
Yes, please.
Okay. Okay, so then this is going to be easy peasy if you have already done the normal birth. So hopefully this is only going to be revising a lot of the things which you already know. And also we are going to be orienting a little bit more of how in OSCE, what are you supposed to be doing and how it is slightly orienting towards the OSCE exam sort of thing. Yeah. So this I have already told you that, there are 4 skills of the birth sort of thing. So which is normal birth, birth scenario 1, birth scenario 2, and complex birth. So around birthing, these are the 4 skills that what we will be going through. Although again, in the same sort of thing, there can be so many different variations there can be. And it is different variations, you have to deal with it. And that is why every delivery is slightly different delivery, because every person is different. But thankfully, the mechanisms of delivery stays the same. And that is what we are going to be learning over here. Yeah, so basically the aim of this station is to know your knowledge of the normal birth and how to manage a patient in the labor. So both the things, you are not only managing the delivery, but you are also managing the patient over there as well. Yeah, so that's why the communication is very, very important, because the patient can be very anxious, and of course they are in pain and all, and it's quite an emotional sort of thing. So we need to be very careful about the communication, and we need to make sure that the female is all the time, she's involved in the care, and she knows that what exactly is going on. So we need to know the knowledge of all three stages of labor, yeah, and you recognize what stage of labor is it that is going on, and we need to assist the patient through it. So now, do you know the stages of the labor?
Yes,
Yes.
please.
Okay, so these are the three stages of the labor. Yeah. So if we see in the stage 1, the cervix is relaxing and it is going to dilate and thin out. Yeah. So that is the stage 1. So where you are waiting for the cervix to fully dilate. Yeah. So, and that normally, as we had discussed earlier as well, that the cervix first, it actually thins out and then it dilates. And especially like if it is your first delivery, then usually it is the cervix is going to thin out first, and then it will quickly dilate once the head start pressurizing a lot on the cervix. In the multipara, normally the dilatation and the thickness and the thinning happens together. And the thinning of the cervix is called what? What do we call it?
Effacement.
Yes, that is called as the effacement. So over here we can see that the baby is, the cephalic presentation is there, and this is the cervix. So the cervix will first thin out, yeah, and then it is going to dilate. So that is till the full dilatation, from thinning out till the full dilatation, it is going to be the first stage of the labor. Yeah, then we come to the second stage of the labor, where the uterine contractions increase in strength and the infant is delivered. So from the full dilatation to the delivery of the baby, that is called as the second stage of the labor. And the third stage of the labor is when the placenta is delivered. Okay, so these are the three different stages. So do you want me to go in detail of any of these three stages? Although we will be, but anything that I need to elaborate in this slide? Or have you understood this one?
We understand, but maybe the procedure or the process here in UK will be different from our home country, Ghana. So.
See, again and again, I'm telling you that in the UK also babies are born in the same manner. Yeah, so it is nothing different from the mechanism point of view. The only thing which is different, or which may or may not be different, I'm not saying that it is different. See, sometimes the only things which are slightly you have to modify or you have to be aware of is that the communication, the way of communication, and the cultural sort of things. Yeah, so the baby will get delivered in the same manner. There is nothing different that you will be doing over here than you have already done in your home place. Maybe you might be using a different type of a towel, or maybe a different type of a sheet. Those things are different, but those things are different from different hospitals, even in your own country as well. So we don't need to get worried about those things. The mechanism of the labor stays the same, that how the babies are delivered, what happens, what are the different stages, how the stages are defined, what do you do, what are the interventions, those stay the same. Okay, so don't get too much worried about, see, the first day that you work over here, you'll know that how things are arranged, how the things are done. And but I can reassure you this much, that the delivery, the mechanism of the delivery, the process, the science behind that is going to stay the same.
Okay.
Okay, so these are also, like, now that we have understood the mechanism of the or the stages of the labor, now we are going to try and understand that how exactly are what are the movements or how the baby actually moves for the baby at the before the delivery, at the time of the delivery, and just after the head is delivered. So it is like a kind of a various kind of movements that the baby is going to be making in order to come out of the birthing canal. Yeah, so now there are few things and they happen to everyone. And if there is any change in these sort of movements, that is where you get stuck. Yeah, so and then there might be an issue either with the passage or the passenger. And that is according to that, we might have to modify. But let us understand that what are these movements? So there are 7 movements which are going to happen, and you can see on the side as well. So the first one is engagement. So we understand what is engagement. Priscilla, tell me quickly,
Yes.
what is engagement?
The thinning of the cervix.
No, that is effacement. But what is
Hey,
engagement?
sorry. The thinning of the fetal head
Yeah,
into
so
the
whatever,
maternal pelvis.
yes. So that is like whatever is your presenting part, whether it is the fetal head or whether it is the buttocks, whatever is the presenting part, the engagement is that when that presenting part is fully inside the maternal pelvis, and it is no more, you are not able to feel it per abdomen. So it has gone behind the symphysis pubis. So that is the stage when the presenting part actually gets fixed. So now it is engaged and the presenting part is fixed. So that is the first thing that needs to happen, that the presenting part needs to get engaged. Then comes the second one is the descent. So after it has engaged, now it is going to go down. So it is going to get descending. Yeah. Then the third step is flexion. Now, what happens is that, say, for example, if you have to come out of the birthing canal, like over here, so once the head is stuck over here, now it needs to flex for it to come out of this one. So the third movement is the start of the flexion. Yeah. And along with the flexion happens the internal rotation. So what happens is the internal rotation is happening with the shoulders. So now if the head is flexing to come out, the shoulders, they rotate so that they are forming the least width which is there, so that they can easily come out or follow the head. And then the extension is when the head is born with the extension. So it fully extends. After it has flexed, it is going to then fully extend. After the head is delivered, the shoulders, they go through or the head actually goes through an external rotation. That is called as a restitution as well. And then it is the expulsion with the lateral flexion. So all these movements, they actually happen so quickly when you are not able to really appreciate these movements, because once the full dilatation is there, from full dilatation to from the step 3, which is the flexion to expulsion, sometimes it's only take a few seconds, like within 30 seconds the baby is born. Yeah, and that's why you are not really able to see all these movements, but believe me, all these movements, they happen. Mercy, have you understood this? Any question that you have in these movements? Do you think that, have you ever seen the head actually, like the external rotation of the head and all those things? Can you think of if you have ever seen it?
Actually, with the external rotation, yes, I've seen it, but it's usually happen just suddenly with the same as the restitution.
Yeah, that's why I'm saying that, because all these things, they happen so quickly that you are not really able to appreciate that whether that is happening. But since majority of these movements are happening inside, you are not able to really see them except the external rotation, because when the head is delivered, there are those couple of seconds before the shoulders they come out, and in those couple of seconds, if you really notice, you will see that the head is actually rotating. Yeah, and then before the shoulders they come out. Yeah, so now anyway, you need to know these steps, that these are the steps which are there, and probably now that you know the steps, then you are now going to be delivering. You can try and see that if you are able to see the external rotation or the expulsion. Okay, so there are now, I think that although we all know these things, but there are just a few terminology that what we wanted to clarify before we go further. I think that majority of them we already know it, but just to sort of again go through or revise them. So you understand that what is the symphysis fundal height? Mercy?
Yes.
You understand?
Yes.
Okay. So just tell me what it is.
Please, is the space is the space between the fundus. Then it's come along the navel to the symphysis at the border parts of the symphysis pubis. Oh, yeah.
Okay, so you can see that, imagine that this is your belly. Yeah. Now on there is the symphysis is the place where your pubic bone starts. So the hard part which you feel on the lower part of your tummy. Yeah, and the fundus is where your uterus has reached, the end part of the uterus. Yeah, so the distance between the symphysis, the hard part of the bone, and the end of your uterus, which has grown, that is called as like the symphysis to fundal height. So you actually just measure it in centimeters. Yeah. Can you tell me that at what age or of the gestation can you start feeling the uterus? Can it come like it grows out of behind the pubis, it comes above, so what do you think that age is, that when you start actually feeling the uterus?
18 weeks and above, or 20 weeks and above.
Okay, so the uterus, you will start feeling it around 12 weeks. So at 12 weeks, it is going to just come out of the above the pelvis, the pelvic bone or the symphysis bone. And at around 20 weeks, it is going to be somewhere around your umbilicus. Yeah. And at, you can say that at 36 week, usually it is just in your epigastrium around over there. And at 38 to 40 weeks, it is actually going to come down a little bit. Do you know that why does it come down a little bit?
Lightning.
Sorry, say again.
Lightning. Descent.
Yeah, so what happens is that the head then is going to start engaging, or the head will come down, because now the baby is getting ready to be born, and because of that descent, the uterus, it will come down a little bit. So at the full term, it is going to be over there. So this is basically like the centimeters that you are going to be measuring it. Usually the centimeters correspond to the weeks of the gestation. So if the symphysis fundal height is around 20 centimeters, then usually it is going to be around 20 weeks. If 30 centimeters, then it is going to be around 30 weeks. So normally this is the thumb rule, but this can also be used to find out if the symphysis fundal height is not corresponding to the gestation, then that might also mean that maybe the baby is not growing that well, or there needs to be ultrasound scan or something that needs to be done to measure that one. Or if it is more than what you have expected, then it is quite possible that you might have to check again that either whether it is a big baby or whether there is a lot of amniotic fluid which is there. So you might have to, that tells us something so that we can take some action in that. And that is the reason that why your symphysis fundal height is important. Okay, so have you understood the symphysis fundal height?
Yes, please.
Okay, then comes the lie of the fetus. So what do you understand by the lie of the fetus?
The position with which the fetus is lying in the uterus, whether longitudinal or transverse or oblique.
Yeah, that is correct. So basically it is measured with the maternal spine. So because maternal spine is straight, so you are going to be measuring with how the baby is lying in alignment with the maternal spine. If it is lying along the maternal spine, it is called as the longitudinal. If it is oblique, then it is going to call as oblique lie. And if it is like perpendicular to that one, then it is going to be called as a transverse lie. Okay. So lie is also important because although in the early pregnancy, it is not that much of an importance because the baby keeps on moving. But as the position sets and you progress towards the term, then the lie is going to get fixed. Yeah, in majority of the cases, the lie is usually longitudinal, and that is in alignment with the maternal spine. Okay. Then comes the presentation of the fetus. So what is presentation, Mercy?
Doctor, presentation is what the baby is presenting with. Whether the baby is presenting in a vectors presentation or whether the head or the bum.
Yeah.
That is
So
what
basically,
I understand.
yeah, which is right. Basically, presentation is that what part of the baby is actually you will be seeing first when they deliver. Yeah, and majority of the time it is going to be the head first. So you can see that these are the various type of presentations that you can see, that it is most of the time it is the head and the occiput. So sometime it can be that which way the baby is turned, but the head is going to be there. Then sometime it could be face, like if there is the baby is head is or neck is extended inside, then the face is going to be the one which you will be feeling first. It could also be bro presentation. So if the extensions is not that much, then there can be a bro presentation. If it is the buttocks, it can be a breech presentation. And sometime it can be, if the baby is lying transverse, it could also be the shoulder presentation as well. And then there are some other emergency presentations as well, that maybe because of, in all these things, there are other complication can also be there, that maybe the hand comes out first, maybe the umbilical cord comes out first. So these all then becomes like a unusual and an emergency sort of cases where you have to like really handle the delivery fairly quickly. Yeah, but the most common part, the common presentation is the head or the cephalic presentation. Okay. Okay, so the engagement we have already discussed, that what is the engagement of the fetus. Then crowning of the head. So tell me that what is crowning? When do you say that it is the crowning has happened?
So when the baby's head is visible at the vulva.
Yes. So basically, when there is full dilatation has happened, and you can see when you do a PV examination, you can actually see, even without the PV examination, you will be able to see that the head is actually over there and the head is not going back. Yeah, it is just staying over there. So that means the crowning has happened. And that is just before the delivery that you will be able to see that the crowning of the head has happened. Okay, effacement, we have already discussed that what the effacement is, but you can see that how it happens. So this is like that how thick the cervix is, and when it is getting effaced, then it becomes thin. Okay, then molding also we had discussed earlier. Are you happy with the molding of the head, that what exactly it is? So you can see that these are the sutures, and when the sutures, they go on top of each other, that is what is called as the molding of the head. Yeah, and it can be of various degree of molding which has happened, that whether you are able to split push back the bones apart, or whether you are not able to. So that is like the +1, +2 kind of molding which we call. Yeah, so that is the molding is to allow the head circumference to be as small as possible so that the delivery can happen more easily. Okay, external rotation and the restitution we have just sort of discussed in a little while ago. So external rotation is that when the head is out and it rotates externally, and restitution is the repositioning of the shoulders to align it with the rest of the body. So that is basically what the external rotation and restitution is called. Have you understood this, or do you want me to elaborate it any further?
Yes, please. Priscilla, are you okay?
I
Yeah, Priscilla.
understand the surface, like just how she explained it.
Yeah, so
Like,
don't worry about it too much, because as I said, that these are the things which happen so quickly that you will not be able to understand that it has really happened.
Right.
But theoretically, you need to know that what exactly are the steps which are there, and what is the reason that why these steps they happen. Yeah, so when you are going to be coming over here for face to face with the dummy, we can show it slowly that, okay, what does it mean and why do they happen? Yeah, because as we said, that when you are going, imagine yourself navigating a very narrow path. So you will, sometime you will go like that, sometime you will hunch back, sometime you will turn around, sometime this way, because you want to come out of that path. And the body is going to try and find the most easiest way to come out. And that's why you keep on sort of changing, rotating and moving a little bit so that the delivery can happen in the most easiest manner. Okay, so now comes the APGAR score. Now, do you understand what is an APGAR score? Do you normally do it, or have you done it before?
yes, please.
Okay, so tell me, Priscilla, what is an APGAR score?
The APGAR score is the initial score we use to determine the well-being of the fetus for the first 1 and 8 minutes. And the A stands for the appearance of the baby, the P is the pulse, the G is the grimace, the other A is the activity, and the R is the respiration. So we use these to determine the fetal well-being for the first 1 minute and the 5th minute when the baby is born.
That is absolutely correct. So you are going to be, so this is just to check that the baby is fine. So APGAR score is the score which is given at the birth, and you do it twice, once at the 1 minute of the birth and then again at the 5th minute of the birth. And the normal score should be 10, because there are 5 criterias, and if everything is normal, then you are going to give it 2 to 2 for each. And if there is anything which is not right, then accordingly you are going to give the score. And anything which is below 7 is sort of considered as a worrying sort of thing, and below 3 is the critically low. So this is something that the the midwives also use, and if there is a pediatrician who is there, they are also going to be using to describe and to say that what is the baby's condition when they are born. So we need to be aware of the EPGAR score and what does it stand for, what is the normal score and what is the low score and what to do about that one. You understand all these things? What do you understand by grimace? How are you going to be checking the grimace? Either of you, Priscilla or Mercy, tell me, what do you understand by the grimace? Hello, can you hear me?
Yes,
Yes.
please.
Okay, so grimace is actually it's how the face, it is like, not even, I wouldn't even call that it is a smile. Yeah, that has, it's almost, you know, that how when the babies are born, they have a very typical expression when they are born, and the face is like they're almost going like that and like that, so trying to sort of making faces. So that is basically called as a grimace, as if that everything is waking up. Yeah. So just what the expression is there on the face, that is called as a grimace. Okay, any questions so far, like what we have done till now? Any question?
No, please.
Okay, that's fine. So then you understand that what is the placenta and umbilical cord?
Yes.
Yeah, and do we know what the functions of the placenta and umbilical cord are?
Yes, please.
Do you want me to explain anything in that one, or are you quite happy with the what placenta does and what the umbilical cord does?
Mercy, do you want her to explain or we should just move?
Doc, please explain. Maybe you add more information for us.
Okay. Okay, but generally you know that what placenta is. So placenta is basically, it is an organ which it's like a special organ which is meant only for this special purpose of providing the food and nutrients to the baby. Yeah, when the baby is growing. And that is one of the first sort of things which happens along with that when the baby is conceived. So it is going to be the placenta, which is stuck to the womb or stuck to the uterus, and then there is this umbilical cord is like it is a, you can say it's a link between the placenta and the baby. Yeah, and through all of these things, that whatever nutrients are required, they are processed from the placenta, from the mother, and the placenta are the one which are connected, and from the mother things come to the placenta, and from the placenta they are processed and they are going to the baby. Okay, so basically that is the main function of the placenta, to provide the nutrients to the baby. Yeah, and umbilical cord is the one where the connection of the placenta to the baby. There can be a lot of other issues which can happen with how and where the placenta is placed, but that we will discuss at some other time later on. But normally, the placenta in pregnancy, you will see that it is more closer to the internal os. But as the pregnancy grows, the placenta moves up and it goes towards the top of the uterus. And so that it becomes safe for the baby to get delivered and the placenta is not coming in the way. Yeah, but there are certain things which can happen with the placenta which can cause complication in the birth, like if the placenta does not move. So if there is that is called as the placenta previa. So the placenta is actually blocking the internal os and the baby can't be delivered normally. Or if the placenta gets detached before the baby has been born. So, or if there is some bleeding that happens over there. So lots of different type of placenta problems are there, and which we need to be aware of. But generally, just to, in the nutshell, placenta is a special organ. It is the main function is just to provide the nutrients to the baby through the umbilical cord. Okay.
Okay.
Now we can see that what does the placenta look like. Now the reason that why I want you to understand this is that because in the exam you will be asked to sort of check that the placenta, and you will need to know that what does the placenta look like and how to check to make sure that the placenta is complete. So when the placenta is delivered, then I'm sure that even in your normal sort of day-to-day thing, that you would be required to check that the placenta is complete and that there is no lobes or nothing is left behind in the uterus. Because if that is the case, then that can lead to the postpartum hemorrhage, because the uterus will not contract completely if there is any retained products left over there. Okay, so you can see that the placenta looks a little bit like a disc kind of a thing. Yeah, and in real life, in actual, the color is going to look very purplish sort of color. And on one side, it is covered with this thin membrane, they call as the amnion. So this is the outer side of the placenta. And then the other side, you will see all these lobes which are there, which are the part which actually gets stuck to the uterus. Yeah, so then there are lots of blood vessels you will see, because these are all the nutrients from the maternal side comes to the baby. With the root is all these blood vessels. So you will see that it is lots of blood vessels with the red and bluish in color. So the veins, as well as the you will see the veins and arteries over there. And the color, as we said, that it is deep reddish to bluish in color. And the outside is going to be more grayish over there. Now the size is around 10-inch long and 1-inch thick. And when we say 10-inch long, it is like the diameter of it is going to be around 10-inch. And it is around 1 inch of thickness is there. And it can weigh around 16 ounces or around 1 pound. Yeah, so 1 pound is almost like 450 grams kind of a thing. So just roughly half a kg kind of a thing. So it can weigh around that much. And the delivery of the placenta happens after, that is the third stage. And usually within the first 5 to 30 minutes, the delivery of the placenta should happen. Now, majority of the time, you will see that within the next 5 to 6 minutes, normally the delivery of the placenta happens. Yeah. So this is few other things that you need to understand about the placenta. Yeah, all clear about this one? Can you imagine? I'm sure that you would have seen the real placenta anyways, but can you imagine that along with this one? That what am I talking about?
Yeah. Doctor, please. So, if you are given a birth scenario, when you deliver the placenta, will the examiner ask you, or you will just verbalize that the membranes and the fetal blood vessels are intact, or?
Yeah, you will need to verbalize, because they will give you a dummy placenta as well. The dummy placenta is going to be over there. Yeah, and you will need to show and say that, okay, the placenta is looking complete, because there will be lobes that you will be able to see it exactly in a similar sort of manner. So you will need to verbalize all these things.
Okay. So in the exams, it's always complete, right? Like, it's always complete.
Yeah, so they are not going to be giving you something that, okay, because see, if they give you which is an incomplete sort of thing, then what do you do? Because that is going to complicate your scenario, and your scenario is not a complicated scenario. It is a simple, normal birth. So all the normal things will be given to you. All the normal things are going to be asked to you. Okay, because they want only to test that whether you are aware of the normal things. Okay.
Okay, thank you.
Okay, so now just very quickly, we can have a look at what are the disorders of the placenta. As I had already told you that there can be placenta previa. Placenta previa is basically when the placenta is lying covering the cervix. And that is why the baby cannot be delivered. And that is the reason that if any of the female, if they are coming with the history of the PV bleeding, until and unless there is a supporting ultrasound saying that the placenta is not the reason for the bleeding, you should always consider that one and should not be doing a PV examination. Yeah. So first, it is very, very important that we rule out that it is not placenta previa. And for that, we normally will be doing an ultrasound scan. Only then can you actually do the speculum examination to see that where the bleeding is coming from or what is the reason for the bleeding. Okay, so placenta previa is something which is, if that is the case, then we need to, the baby need to be delivered by a cesarean section. Then placenta accreta is the one when placenta is attached too deeply to the uterus wall. Yeah, see over here, if you see in this picture, and I'll show you this one. So if you will see in this picture, a normal one is going to be just attached to just the very thinly to the inner walls. Yeah. But if there is a, sorry, Priscilla, you want to ask something?
I'm just seeing midwifery OSCE skill based on my.
Sorry, say again.
Are you showing anything on the screen, please?
Yes, I am. Mercy, can you see it? Can you see my screen?
That's why. It's just midwifery OSCE skill that I'm seeing.
No, so I'm showing you the placenta. Is it just now, or have you not been able to see it from the very beginning?
From the very beginning, it's just a midwifery OSCE that I've been seeing on the screen.
Mercy, can you see my screen? Because I have been changing the screen since then. Mercy, can you see it?
Oh, really?
Hello, Mercy, are you there? I'm just going to stop sharing and then I'm going to share again. See that if that will help. Okay, can you see it now?
But doctor, you share it right on the page.
Yeah, so can you see, like you should be seeing the placenta, the abnormalities of the placental implantation. No? Okay, what do you see now?
I'm seeing you on the
Okay,
screen.
that's fine. Okay, good. So I'm going to be now sharing it again and hopefully you should be able to see my screen. Mercy, are you there?
Yes, please.
Can you see my screen?
Yes.
What do you see?
Abnormalities of placenta.
Okay, so you can see my screen. So
Yes,
Priscilla,
please.
can you see the screen now?
No, I'm only seeing SB. Maybe it's my network. We can continue.
No, you have to see it first. I think so.
It's not coming.
how do I don't know, that looks like that it is the issue on your side, Priscilla, because if Mercy is able to see it, then it is more of on your end. Do you want to log out and log back in to see that if that would help?
Okay. Yeah.
Okay.
Okay, I can see now.
Okay,
Oh,
that's
boy.
great. Okay, good. So let us carry on. So we were discussing about the abnormalities of the placental implantation. So you can see that in normal, that how the placenta is attached. It is going to be quite a superficial sort of thing, or a thin layer which is going to be over there, which is going to be separating the uterine wall in the normal pregnancy. So this one, the dark one that you will see, that it is the normal sort of thing. But in placenta accreta, what we are saying is that it is going to be, it's as it says, that 79% of the abnormally implanted placenta. So placenta accreta forms that if there is abnormal implantation, then 79% of the time it will be the placenta accreta. So what happens is that it attaches a little bit more deeply with the uterine myometrium or the uterine muscles. And then there is the placenta increta, which is like almost encroaching at half of the uterine muscles over there, and it is going more deep into the uterine myometrium. And the placenta percreta is the one which is totally covering the myometrium. So now these becomes very, very difficult to get detached. And that is why they are the one which then can lead to the placenta or the PPH and difficulty in the delivery of the placenta. So it is very, very important to understand that what can be the various form of or various issues that can happen with the placenta. So again, you don't have to go too much into depth of it. You just need to understand that what is like a normal placenta. So it is attached thinly. Placenta accreta is that when it goes more deep into the muscles of the uterus, and increta and percreta are depending upon the depth, that how deep they are. Increta is that almost half, and percreta is like it is almost covering the whole of the myometrium. Okay, do you understand this one?
Okay.
Okay, so then we come to the umbilical cord. Priscilla, can you see this screen?
Yes,
Did your screen
please.
change? Okay,
Yes, I
great.
can see.
So now that we know about the placenta, we also need to know about the umbilical cord. Now the umbilical cord is basically the attachment which is there on the maternal and the baby side. Yeah, so as we said that it is attached to the placenta. From the placenta, it transferring the nutrients to the baby. So it is almost, you can say that it's physical as well as the emotional attachment which is there. That this is how the baby is attached to the mother. Yeah, and all of the nutrients as well as the oxygen, the maternal, the blood circulation and everything happens through the placenta and through the umbilical cords. And also removal of the waste products from the baby also happens from the same sort of route as well. Now, normally the length of the umbilical cord is around 50 to 60 centimeters, and the diameter is around 1 centimeter in the diameter. Yeah, and the composition, it is going to be consisting of 3 vessels. Now, this is also very important because in the exam, you will need to actually show the examiner that the umbilical cord is looking normal and it is consisting of 3 vessels, out of which there are 2 umbilical arteries, which are like smaller, and 1 umbilical vein. Now, if you will see that the umbilical arteries are going to look slightly bluish, and they are the smaller ones which are entangled or entwined around the umbilical vein, which is going to be more thick and it is going to be a bigger one. Okay. So when you are after the baby is born, now you need to clamp the cord. Yeah, because you need to then make sure, because you are going to be detaching the baby from the mother. So, and that happens by clamping of the cord. So now there are 2 types of clamping that you can do. One is the early cord clamping, which happens within the first 60 seconds after the birth or first 1 minute. And then you can also do the delayed cord clamping as well. And that is from 1 minute to 5 minutes after the birth, or if the cord pulsation has stopped. So sometime when the cord is pulsating means the blood is still going into the baby. And that is why sometimes you might need to leave it a little while longer and you can do a delayed cord clamping. Yeah, but generally it is that we do the cord clamping pretty much straight away. And both of you are okay with how to do a cord clamping and cord cutting?
Yes.
Yeah, so there are the clamps that you would have even in the exam. There are going to be the clamps which are going to be available. And these clamps are like you need to have 2 clamps. So one, you will be putting the clamps about 1 to 2 inch apart on the umbilical cord, and you are going to be cutting the cord from in between. Now, the reason that why we are clamping it twice is that we do not want any flow of the blood from the mother or the baby side, because if you are only clamping it on one side, then the other side might just bleed. Okay?
Okay.
So again, pretty straightforward and very common sort of thing. Now, this is how, see, this is where you can appreciate the grimace. Yeah, so it is a very typical expression that the babies will have. Can you tell me that what is all this whitish sort of thing which is there?
I forgot.
I think it is called as the linea alba. Yeah, so something like you will see that the babies are covered with this very sticky sort of greasy kind of a white colored material, which sometimes is difficult to remove in just one sort of term, and maybe it takes 2-3 days for it to go away. Yeah, so that is almost more like that in the amniotic fluid when the baby is there, so that it just protects the skin. Yeah, so in the now what we have learned so far is that in the normal birth, we have learned the stages of the normal birth. We have learned that what are the 7 movements which is going to happen in the normal birth. We have learned about that what are the various sort of definitions that you'll need to know about the normal birth. We have also learned about the Apgar score. We have learned about the placenta and the umbilical cord. Yeah. Now, so these are all of the things which are you need to know when a normal birth or a normal baby is being delivered. Now, normally you will, in the exam, you will also be given a trolley, which is going to be over there, like a birthing trolley. Now, I'm sure that you are already aware of all the items that you are going to be requiring over there. But generally, the items which are going to be there in the delivery trolley are gloves, apron, scissors, artery forceps. There are cord clamps which are there. Sponge holding forceps are there. Urinary catheter, if required, it is also there. Then there is a bowl for antiseptic solution, gauze pieces, cotton swabs, speculum, sanitary pad, kidney tray to hold the placenta, the baby holding towel, baby cap, and a baby nappy. And one thing which I have not mentioned over here is also that you can have an episiotomy forceps, scissor as well over here. Now, do you understand what is an episiotomy?
Yes.
Have you ever done an episiotomy, given an episiotomy?
Yes, I've been given episiotomy.
Are you happy to do the suturing of the episiotomy?
That one for me, I'm not really good at it yet.
Okay.
So
Okay.
I relocated.
Okay, that's fine. That is something to be learned, and you'll learn it. So don't worry about that one. Okay. So this is basically all of the things that what you need to know about the normal delivery, and what all are, how and what all are the stages which are going to be over there. Now, in this one, there is one more thing that I would want you to sort of really understand. Let me just see. These are just the top tips, the same sort of things as what we have normally given. But there is one more thing which I really want to go through is that I want to take you through the criteria of this one, so that we can really quickly understand that what is the criteria and what all are the things that you should be doing. Yeah, so that you can correlate with what we have just gone through. Okay, so just give me a minute.
Okay.
Okay, can you see my screen?
Yes, please.
Now, we are just going to quickly read through this assessment criteria so that you know that how or what all are the steps that you will be required to show or in the exam to make sure that you have done or you have displayed that you are fully capable of conducting a normal delivery. Yeah. Now, when you are going to be coming in, so you will be given like a scenario is going to be that, okay, that there is this term, there is this lady who is full term and she is in active labor, and she's in the second stage of labor. They can say that she's in the second stage of the labor, and it is you have to conduct a normal delivery on this pregnancy, and they might also tell that it is a cephalic presentation is there, and all the antenatal everything has been fine. She is okay with all her vital signs. The mother is okay with all the vital signs, and it is going so far. Everything is going fine with the delivery. Now it is the second stage of the labor, and you have to conduct this delivery. So your first things are going to be, and they can also tell you that it is the right patient that you have, and the patient has already given the consent for the delivery. So your introductory 6, you will not necessarily need to do the introductory 6. Yeah. So, but what you can quickly do is that you can quickly tell the female that, okay, my name is so and so, and I'm the midwife who is going to be looking after you or supporting you throughout this normal delivery. Yeah. So then you are going to be, first of all, it is going to be very, very important that you are reassuring the woman, and you are going to be encouraging as well as helping and supporting her throughout the contraction. And you are going to be telling her that, okay, say for argument's sake, let us just think that Helen is the name of the patient. So you can say that, okay, Helen, I'm going to be supporting you through your this delivery and all the contractions, and I'm going to be letting you know when I'm able to see the head of the baby. Yeah. So you are going to be making sure that you are reassuring the lady. Yeah. And after that, you are going to, so over here, as it says, that the candidate should demonstrate the auscultation at least once during the second stage of labor. So you are actually, there is going to be this fetal Doppler is going to be over there. So you will have to show that you are able to check that the baby's heartbeat is going on all right, and there is no signs of any distress which are over there. Yeah. Then you are going to be saying that you are going to guide the woman appropriately to encourage controlled delivery of the head during crowning. Now, what do you mean by that? And what are you going to actually tell? How do you guide in this one?
Normally, we tell the women to push with contractions and rest in between
Absolutely.
contractions.
Absolutely. So that is exactly what you need to do, because you don't want her to be unnecessarily getting tired, because if you keep on pushing all the time, it is anyway not going to be of any help. So the lady needs to be pushing with the contraction. Yeah. So that is what the encouragement that you are going to be doing to give her the controlled delivery towards the or heading towards the crowning of the baby. Now, once the crowning has happened, you will also be telling that you can use either the hands-on or hands-off position, or hand poised position, that you can say. Have you ever tried doing this one? Majority of the time, I have seen majority of the time that it is usually a hands-on sort of approach that
Yeah,
everyone takes, because
yeah.
that feels like more helping and supporting.
Mm.
Yeah, but and you can tell in the exam as well that, okay, I'm going to be taking a hands-on approach. Yeah, now remember, at this time you are wearing your gloves and your apron as well. Yeah, so that you will wear in the very beginning itself. As you will enter the station, you will wear your gloves and apron, because you will require that one. So you will say that I'm going to be taking a hands-on approach. And by hands-on approach, we mean that you will be guarding the perineum and flexing the head. So now by doing this, what you are trying to do is that when you are guarding the head and gently flex the head, that is that you are allowing the baby to be born without the risk of having a tear to the mother, or a tear to the perineal tear to the mother. Okay, so you are trying to guard or the perineum, or trying to push the perineum and flexing the head so that it can gently come out, the head can be delivered. Okay, so but you are going to just be gentle, and you're just going to be facilitating, so that when the head comes out, you are giving that time for the restitution, internal rotation, and lateral flexion, all those sort of things. But mind you, all these things are going to happen very quickly in real life. So although it feels as if that you can give time, but there is actually no time after that. So, but anyway, once all these things happen in the exam, because it is going to be a dummy, the examiner is going to be pushing the baby from the other side, and you are going to be showing that, okay, these are what is happening. And then you are going to be delivering the baby. Once the head comes out, after that, there is the restitution, internal rotation, external rotation, and with the flexion, the baby is born. Okay, so when the baby is born, you are going to immediately see that the EPGAR score, you are going to be noticing that one, that what is the EPGAR score of the baby at the first 1 minute, that the baby is crying. So you can, this is again because there will be no crying or nothing, but you will have to verbalize this thing, that I can see that the color of the baby is looking fine, the tone is good, the grimace is there, baby is crying and moving and all that. So the EPGAR score is looking around 10 at this moment. And you are going to be placing, so when you are going to be taking the baby, you will be receiving the baby with the towel, or that was there on the tray. So you will receive the baby with that towel, and you are going to be placing the baby on the mother's abdomen for the contact, like the skin to skin contact. And you are going to be covering the baby with that one. So the skin to skin contact is there, but with your towel, you will just cover the baby so that the baby does not feel cold. Okay. After that, now this is something, because we now need to get ready to the delivery of the placenta. And that is where that you will verbalize the need to administer 10 international unit of oxytocin by intramuscular injection. Now, what does oxytocin do?
It stimulates contractions.
Yes, so it is a uterotonic medication. So when you give the oxytocin, it is going to contract the uterus. And when the uterus is going to contract, it is going to release the detachment of the placenta is going to happen. So it is going to facilitate the separation of the placenta. So the placenta, so you give that one, and on the side, then you are also going to clamp the cord. You'll clamp the cord and you are going to cut the cord. You can tell that what is that whether you can do it 1 minute or 5 minutes sort of thing. So once you have cut the cord, the baby is safely over there on the mother's doing the skin to skin. You have already given the oxytocin for the placenta to be separated. Now you'll just wait for a few minutes to see whether you have got the signs of the placental separation. Now tell me, what are the signs? How will you know that the placenta is separated?
Elongation of the cord.
Yeah. And there is also going to be a sudden gush of the blood. Okay, and the uterus is obviously going to get hard because of the it is contracted. So then you will need to deliver the placenta, and the way that you deliver the placenta is by the controlled cord traction. So when we say controlled cord traction, how do you actually perform the controlled cord traction? So normally we would do is that one hand we are going to be putting on by supporting the uterus. Yeah, and with the other hand, we are just going to gently try and push the placenta outside. We'll gently pull the cord so that so one side we are pushing the supporting the uterus, and the other side we are pulling. So it is like a controlled cord traction. So we are giving a traction to the cord, but we are controlling the uterus as well, so that we can just pull the placenta out. Once the placenta is out, you are then going to be checking. So you take the placenta or receive the placenta in the kidney tray. So once you have taken it out, you are just going to put it in the kidney tray, and then you are going to be checking the placenta, that it is the outer membrane, the umbilical cord, the vessels, blood vessels are there, and all of the lobes on the other sides are also present. Okay, so this way you have completed the stages of the delivery. But after that, you are just going to verbalize these things as well, just to check the external genitalia, vagina, just to see if there is any tear or if there is any soft tissue damage or anything of those sort. You are going to also give a slight estimate of the blood loss, which is generally over there. So generally it is like 150 to 200 ml kind of a blood loss normally will happen. Yeah, and then you are going to make sure, and these are all like verbalizing. So you are just going to be verbalizing these things. You don't have to do anything. You will verbalize that I will ensure that the woman is comfortable. It is, you are going to be cleaning, give her a clean pad, change the sheets and things, and you are going to be covering her up to maintain the dignity. You will also, after that, you will follow the maternal observations by checking the pulse, blood pressure, temperature, and all those things. And you are also going to be completing all of the documents. So all the rest of these things are going to be a lot of verbalizing that you will need to do the steps. So you don't have to perform anything. You just have to say, verbalize them, because it's just a dummy that you are going to be having. There is no actual person over there. Okay, so this way you are going to be completing your the normal delivery.